Today we have the renowned fertility scientist. He is also leading the research wing of the Indra IVF. The babies are getting mixed up. How do Indra IVF manages that they don't get mixed up?
Here, the whatever is happening is behind the door in the lab, and patient doesn't know anything.
You are dealing with a live egg and a sperm. How important are the managing temperature to keep everything in place?
Unique part about the Indra Fertility Academy is that we put them on simulation. You can create a real scenario, real conditions, complication you can create. People are still skeptical about being a part of research. They feel like something will happen to me, something will happen to my treatment.
Because currently the implantation is 50-50 process. It's natural.
There are a lot of genetic variations are there. Any good embryo can fail.
Do you see that government is doing any support system for inculcating the research aspect of India?
It's very, very difficult to happen. To incorporate that knowledge into the IVF from the very beginning, not many people are doing so.
Where does the male infertility factor going in India?
In India, nobody is doing much of male infertility. So either is the self sperm or donor sperms.
Hello everyone, welcome to this Fertility Insight with me. And today we have the renowned fertility scientist and fertility researcher as well from the India's largest and most trusted clinic, Indra IVF. The Indra IVF has over 180 clinics in India, and they are planning to have clinic worldwide as well. And in the clinic they do over tens of thousands of ICSI treatment, which is advanced IVF, and so far the Indra IVF has successfully delivered 175,000 live birth. He is also leading the research wing of the Indra IVF, and he has the expertise in fetal and reproductive medicine. He do a lot of research with clinics and scientists and doctors from USA, Europe, and Asia. So, Dr. Chandra, welcome to this podcast.
Thank you. Nice to be over here.
Doing an IVF is one thing, and starting one clinic is another thing. But scaling up, from one clinic to 180 clinic, and that also giving the same standard of treatment across all your clinic. How can you explain how this task get done at your Indra IVF?
Expansion is it's a business part, but expansion do happen only once you have some standardization in your processes and protocols in your training. So everything one can do expansion only when they have a bench strength ready and the processes are set in place. Then only you can deliver good outcome. And for that, to achieve that one, what we have done is we have a standard SOPs everywhere, whether it's for clinicians, whether it's for embryologists, whether it's for the IVF nurses or counselors, starting from stimulation, pre-stimulation to drug, deciding the doses, triggers, everything is in a setup as a set and as an SOP, what to be the luteal phase support and all. From there to the embryology, everything is has an standard protocols for everyone, and everyone has to abide that. Before that, also we have a very centralized recruitment process. We do take them whoever the embryologists or clinicians get absorbed with us, they get as common training program. They have to undergo a common training program. Again, that set the pace from the beginning, that we wanted to have an standardization across all the staff as well as all the zones of an IVF, you can say. And along with that, we have a regular audits within ourselves from the clinical side as well as embryology side. We have dashboards where we can see the KPI moving, how any doctor, embryologist or a unit is performing, what delivers, what they are delivering in terms of an outcomes and all. Anybody is lagging behind, we can ask them, we put them on a PIP, bring them back to get that retrain at the Indra Fertility Academy. And likewise, we try to achieve a standards, because until unless you don't have a standards, set SOPs and common training, things cannot these outcomes and the expansion would not be possible.
So you talk very good about that you need a particular standard and SOPs. Now, 180 clinic or 182 clinic you have at the moment, how many people we are talking about? How many embryologists? Roughly, what is the size of the Indra IVF? All the people, counselor, and everything.
So all means back office, front desk office, clinicians, embryologists put together. Present headcount is, I think, 5,000 plus. Among
5,000 plus.
5,000 plus. Along with them, the core clinicians are around 350 plus. Embryologists are around 250 plus.
My God. So you are managing all the training of these many people via your Indra IVF Academy, Fertility Academy.
Yes, yes. So everyone who got recruited for any location, they have to first get trained in the Indra's Fertility Academy for 4 to 5 months. Once we and every month there will be assessments also, and then once the faculty at the Indra Fertility Academy make sure that they are in the right direction, they have achieved enough training and they are independent to go for to do the procedure, then only we'll let them go to their base locations.
That's wonderful. Managing this many number of clinic is require, whatever you will do will be setting the standard for the world.
The unique part about the Indra Fertility Academy is that initial 15 days or 2 to 3 weeks, we put them on simulation. So we have a simulators for ovum pickups, for doing ultrasound, abdominal ultrasound, vaginal ultrasounds, hysteroscopies, all the aspects where clinician has to go and touch the patient. All those procedures are there as a simulators.
So you have a simulator for all these
For
things.
yeah, hysteroscopy, embryo transfer, and everything. And these simulators are next to like a
Realistic.
real scenarios. You can create a real scenario, real conditions, complication you can create, and then the system simulators give you the scoring about how the patient felt about the procedure you done on him. What is the optimum time you should have done, have you done it performed in a right way or not, and then they scores you. Once the everybody pass through all the aspects which are needed from transvaginal scans to pick up embryo transfer, hysteroscopy, laparoscopy, then only they are allowed to go to the clinic and touch down the patients.
Okay, that's wonderful. Now you mentioned about this training aspect of all these clinician, embryologists, and other thing. One particular aspect which we often, the different clinic have different pricing, and the pricing some has low, some has high. Now, often to make a proper standard, follow the protocol, like a training of the people and managing the people, finding the KPI meeting or not, where the fault is happening. If they're not doing good, then you have to retrain them. That add up to the cost. Now, when you set a standard, there are certain things are needed for the clinic. You are dealing with a live egg and a sperm for doing the IVF process or fertility process. How important are the managing temperature, managing standard chemicals, which has the international standards, and managing different kind of equipment of the better standard to keep everything in place for the good outcome of IVF.
Professor Prasad, this is a very right question, and I think any upcoming corporation can learn from this. First of all, we don't compromise on the quality of the instruments or the products we want to use in our IVF process. Second point, that whatever the doctor have to use in their own clinic, we get them trained on that same kind of instruments. So our academy is have a all those equipments, be it from ultrasound machine, be it from incubator, be it micro manipulator, be it a bench top, be it anything you say, from cryo to hysteroscopy, every instrument is the same which they gonna use in their own clinic. So from the day one, they become very friendly and customized with the instruments they're going to use across all the 180 centers. You will gonna find the same machines, same infrastructure, so that there is nothing like a variation is there from the infrastructure side of it. So there is no biases. If the patient goes from one place to another place, patient from a Jammu clinic goes to the Chennai clinic, they're going to find the same kind of infrastructure. Coming to the question second is that commercials. So all if you go for better outcome, definitely you have to go for an good products, and each good products come with a price tag. Since we work, we have a leverage, or you can say luxury. Since we deal in the volumes, we have a good pricing. We get a good pricing as with the vendors and all. So, but we don't compromise on the quality of the products, whether it comes from the media, wherever it comes from consumable. So all the products are a top-notch quality whenever it comes, and they say, for example, when it comes to the consumable, they should be MEA tested, IVF grade kind of a consumable only. Then only they will allow to be utilized.
So coming back to this consumables and other thing, so since we both are going to a conference called ESHRE or ASRM this year, and in these conferences there are 1,000, 3,000 companies to come. So now Indra IVF being the very big clinic, it has a large, so lot of companies are approaching to you with their products, their chemicals, and how, because you are a chief clinician and the head of the lab operation of Indra IVF, how do you manage so many requests? And if any product is coming into your clinic, how, what process you follow?
We don't go by viewing them or by just being someone has said a good put up a good remark about them, or the product is seems to be good one. What we do is we list down our priorities, which update is coming in the products, or which new product or new technology is coming, which we need to uh, uh, absorb with for in our processes. Once it has been identified that this, yes, this is the new technology which is coming up, we have to have this technology or equipment, or even a drug molecule, then we'll take them for a pilot study. We do a pilot within ourselves on 30-40 patients, where we can make out some statistical significance, whether it's clinically significantly improving or contributing or adding to the to our KPIs or our values. Then only we go for and as well as the patient compliance, whether the patient is compliant with that or not. So once we are comfortable with non in these two aspects, then we go for commercial
You
negotiations.
know, the movies are good in increasing the awareness. Movies have increased the awareness regarding the fertility, but movies are also scaring people. Like recent movies came up where the babies are getting mixed up. How do Indra IVF manages that they don't get mixed up? Or is it happen really? Or it is just a movie?
So logically, yes, it can happen. But if you put up processes and all, it's very difficult to happen. Why so? Because on social media, or on in movies, they casually come up with this mixing match happening up. But if a lab, because IVF is always about trust and transparency. Other fraternities, things are all means operations are happening on the patient itself. Here, the whatever is happening is behind the door in the lab, and patient doesn't know anything. And there we need to have a trust and transparency, and to have a credibility of that the mixing will not happen. IVF lab need to have a stringent processes where witnessing can be done properly, so that the cross mix match of the gamete should cannot happen. A long back we used to have a double witnessing, which is a usual norm which everybody follows. But over and above that, we have started electronic witnessing system. Now we are the only one in India having electronic witnessing system enabled across all the processes and steps of the of ART procedures, across all the centers, all the starting from the collection of the sample to the embryo transfer. Every process is been tagged or witnessed by the electronic witnessing system. People usually do use two identifiers to identify someone.
Mhm.
We started doing three identifiers now, so that other for we are adding another layer, so
What is
that we,
the third identifier?
anything like usually people use name, age, or mobile number. Then similarly any three identifiers can be utilized. Yeah, date of birth. So yeah, so mix and match. We have our own set of standard three identifiers, which are, so we are adding one more layer to our witnessing and traceabilities, so that the mix match and uh, won't happen. You may be thinking that I'm doing the best for my patients, but there may be some lacunas where there may be gaps in the processes, and in your approach to the to deliver the outcomes, there where any external auditors do come and they assess you across all the journey for all the patients from what been offered, how the documentation happened, what is there any lag, any gaps in the processes or not. All these been once been audited from by the external one, they you become a foolproof. They give you suggestions where to improve and all. So Indra is again is all the centers of Indra is been accredited by QI, which is an QI accredited. As well as we started last 3 years, we started the journey of on getting our centers being accredited by the Arctic Society of Australia and New Zealand. Now we have 12 centers being accredited by the one of the best accreditation body in the world.
So, how regular is this audit process? Means quarterly, half yearly, annually, means or different type of processes get audited differently.
So we have our own audit department for clinical side as well as embryology side. We do even for the biomedical side also. So as well as there is a separate body for the separate department for the clinical excellence. So all these three department, all these 3 4 department, they do conduct their own audits at a regular frequency every quarter. They come up with an audit reports. Whatever comes in the audit report is the finding and all has been discussed with the respective departments, staff of that center, and we'll try to close them with the improvement with the expectation to improve in the subsequent cycles. So this is the internal audit, and then we have an external audits being done by the QI and RT.
So the third party is doing the audit because audit is going to ensure the standards and compliance.
Yeah, it's bring credibility because in today's world, patient gonna ask you what you doing extra so that my mismatch will not happen, my embryos and gametes are safe in your lab.
So now in this, you bring up a very important point, like transparency and trust factor. Now, in the IVF process or ART process, most of the things are happening in the back end. Apart from this accreditation like QE and RTEC, another thing, do you also allow patient to view? Like some clinics are allowing the video-based viewing of the clinic.
In our scenario, we don't have what I say time lapse with us. Other than that, if patient asks for any sperm details, sperms to be sperm images and oocyte images to be delivered to them, they want to view it, they want to have a comment on it, or embryo, they are very
So
well.
you are allowed to
Yeah,
get
we
it then.
allowed to.
So that way the patients are taken into picture.
Are all labs including the satellite hospitals also are equipped with the CASA system. So CASA delivers the images and the videos of their sperm while doing the semen analysis, and we'll give them as a copy to them if they want, and we'll explain them with those images and the videos.
So that is the very wonderful aspect. Like things are in place and trust and transparency is increased. One particular area, since Indra IVF have so big team and you are also handling the research part of it, the research wing of it. Would you like to give some insight? What are the different research Indra IVF is doing in this area?
I'm with the Indra since beginning almost. When I look back 5 years around, we were thinking that we India is somewhat lacking in the academics and somewhat not contributing enough on the on the global platform on any kind of a research. So and that's when we started our research department. Initially, we started with an observational studies and the case reports. Gradually, we established with the complete department in toto, where we have biostatistician, we have CRCs, we have CRA, we have CRO, we have medical content writer with us now. So we have our own ethical committees at the 12 to 14 locations. We have our own SRC committee. So there is a complete pyramid of ecosystem pyramid, and the ecosystem has been well established now and well geared, well oiled for doing any kind of a research. The research flows like this. Anybody who is a part of any department want to do a conduct any study and any idea is there, they are allowed to present their idea research hypothesis in the SRC, which is a scientific research review committee, which happens twice a month. That been evaluated by the committee. If this found good, they will the person has been asked to submit the idea to the to department. Department formulate the proper protocol of the study, and that with that idea has been submitted in the scientific advisory board. We have a few international KOLs with us, like Centro Steve's with us, is there with us. Marcus Massacre is there. Carlos Alvigi is there. And ICMR scientist Dr. Deepak Modi is there with us. Peter O'Madden is there. So all of them are there sitting in the scientific advisory board. All these KOLs then review that protocol. I myself is also there in that committee, and then whatever modification is finally been suggested, once done, we'll go for the ethical committee approval. Once the ethical committee gives the approval, because they are the independent body outside the institute, ethical committee gives the approval, we'll register them CTRI, and then only we conduct the study. Then we have a CRA and CRC who do the recruitment. Get all the studies are been audited. Site assessment, site audit, study audit do happen, and we keep a document and logs for those audits also. Just not the IVF is being audited, the studies are also
Studies
audited
are also
audited so that the sampling is done, recruitment is done in a proper way or not.
in this aspect. When you are you did the IRB, the review board, and approval has been obtained. Now the next part is when you collect samples from the patient. uh, in Indian context, like I come from Norway, where if you go to give a sample, then most of us, we allow our sample to be used for research purpose. If I give a semen sample, then after the semen analysis done, my sample, I can give approval to be used for research purpose. uh, in India, being not so open to research, the research aspect is not there. People understanding is also missing. How do you convince, or do you have to convince people too much, or they are open to research use of their samples?
No, the people are still a spectacle about being a part of research. They feel like something will happen to me, something will happen to my treatment, and if anybody wants to be a part of study, what we do is we properly counsel them. The clinician who is the either co-PI or PI, they do the counseling, or CRC do the along with the CRC, they do the counseling of the patient. What this study is about, what we're gonna perform on you, or then only once the patient has been fully understood, and through informed consent, they sign the consent, then only they are taken into the
Okay,
consideration.
so that is a wonderful. It's like very much like internationally been done. For the research aspect, the IVF, we are already at almost 48 years of IVF process, and millions of kids have been born. What are the different area of this whole cycle? The egg extraction, egg stimulation, to the sperm selection, and then oocyte and blastocyte. So many things are there. Which are the area do you think research Indra IVF is currently looking for?
A lot of studies are going on there. Probably still lot many areas are there where where because of the complexity of biology involved in the reproductive system, and lot many variables are there which need to be addressed while conducting a proper research, and makes the research quite difficult in reproductive medicine. But the area where if somebody want to should focus, and Indra is also trying to focus on it, is how to improvise the oocyte yield across the various categories of the patient, and how we can increase the potential of the embryo, and lastly how we can increase the implantation perspective of each and every. What is the crosstalk happens, because nobody is still lot many gray areas there are when about the implantation. Why a good embryo has been not implanted. So understanding the implantation physiology and pathophysiology of recurrent implantation failure will be our focus of interest.
But the this the oocyte extraction you mentioned, we had been in the past, people were using overdose of overstimulation of egg. Now we are going towards the phase where the stimulations are not being done too excessive. Now, why do you think the oocyte still is an unsolved problem?
There are a lot of genetic variations are there, because it's gonadotropin coming on receptors, and receptors is acting on the on the gametes. So a lot of receptor variants as well as the hormonal variants, biosimilar variants, may be the reason. That's why the one stimulation protocol is giving a good outcome in one set of patients, whereas that not giving a good outcome in another set of patients. And that's where we that area is evolving. Well, lot many people have already started working on the receptor polymorphism as well as the hormonal bivariants to incorporate that knowledge into the IVF from the very beginning. Not many people are doing so. Once it has been very well established that through the research, that what are the variants are there for FSH receptor, LH receptor, E2 receptors, P4 and all, and how they are contributing to the outcomes. And once it has been established, I think we can then I can foresee a day where we'll be doing some genetic study before starting the stimulation and individualizing the protocol basis the receptor variants for that patient.
So means you are looking towards the day where the genetic evaluation is done, and based on that, what will be the stimulation process or the amount of chemical to be introduced for oocyte extraction. But the same thing can be applicable for other aspect as well, the one you are mentioning, like implantation, because currently the implantation is 50-50 process. It's natural. You were mentioning that even a good blastocyte of 4A quality, or what quality you grade it, and still not getting implanted, and still we don't know why it is happening.
Yeah, a lot of scope is there for the to understand why the variation is there in the implantation also. Whether it's the receptivity which is contributing, or it's an embryo which is leading to the failure. Since morphology is not altogether an accurate means measure to say whether this will really give you a guarantee to the success. Any good embryo can fails, and any even a just okayish kind of an embryo like 3BB can give a good pregnancy. Morphology is nothing is should not be the one way to look at the IVF success, because lot many things are there at the beneath, be it genetics, be it molecular health of the baby of the embryo, which actually may be contributing, but we don't know right now. And these are need to be evaluated.
You well said that lot of research to be needed. Now, do you see, means the India is progressing. We are progressing. We are growing in economy and other thing. From the governmental focus point of view, do you see that government is doing any support system for inculcating the research aspect of India?
Government has already taken some good steps for safeguarding the patients, and by putting up a regulation so that the any unethical practices can be avoided. And that's the first goal post for any good industry. You should have a regulation
Regulation.
set in place. Already government has put up a other institutes are there which are semi government or government institutes are there, which they have their own IVF and IVF system, where they can perform research relevant to the reproductive medicine. We as being a private player, we do have some tie up. So whenever we need, we go and have a
And
tie up with
I,
these government institutes also to get the good research done.
so government is promoting the industry and academia
Yeah,
collaboration
I can.
better way.
They are doing what they can do best at their level. But I am foreseeing that soon India will have from the government side, there will be good
Good push
push
for.
for the research and
So
innovations.
keeping finger crossed, we will have
Yes.
more activity coming from there.
Yeah.
Now
Make in
the
India may come up in the
so
IVF
make
industry.
yeah, research in India. We should have research in India. Instead of make in India, research in India should also be promoted. Now the IVF, that it is a well confused and scary and over promised for many patients. The people are saying go for IVF, and currently the IVF is not 100% technological problem. We just discussed the implantation, whose site manufacturers are there, and that makes it not 100% process. How your Indra IVF keep the expectation into the accepted level of IVF success rate?
So first of all, our counseling starts from the very beginning. So a good clinic, when I say, is one who educate the patient rather than pushing on the patient, rather than impressing the patient and guaranteeing the patient. If you educate and make them learn about what the process is all about, you consult them properly about the alternatives available, the process in such in as a whole in such, as well as the all risk and complications and the prognosis also, what's the expected outcome also, and what are the possible ART procedures which may go through. So if you are transparent in these and counsel them from the very beginning, their journey becomes easy. They will not get surprised. What we do is, so our counseling get initiated very beginning and from the very first visit itself, and we have one very unique process set in our whole journey of an IVF. Whenever the patient is about to come for the means supposed to come for the next visit, what we do is we do counsel them that what's going to happen in the next visit, what they are going to expect over there, what we're going to perform, what the procedure will be look like, what will be the documentation requirement, how you going to come over there, all the needs, and the setting is of their mindset has been done a visit before.
That is wonderful. The you are managing the patient expectation. Otherwise, when the failure will happen for some cases, then they will not be blaming the clinics
Yeah,
so much.
setting the expectation about the, especially for the outcome, because IVF itself is a very long journey, and second, it's cyclic. Okay, one cycle can give you good result, another cycle may not give you a good outcome. So you, as a clinician, you need to be very transparent about what is going to be expected in your case. At masses, there may be 60-70% may got a biochemical pregnancy for, but for your case, whether how you gonna achieve it, what will be your the cycle success rate for one cycle or cumulative one, all are being discussed with the patient at large.
So that is a, good thing, maintaining the patient expectation. In the back, we were talking about that you representing as a male infertility as an ambassador at ISHRE conference, which is uh, one of the biggest reproductive conference. Male infertility related aspect. What do you see? Where does the male infertility factor going in India, or you have any opinion about this particular area?
No, I'm not representing. One thing I want to correct over here. I'm not representing as an ambassador in industry, but yeah, I have a do have a great interest in male infertility, and we are collaborating. You must be knowing Centro Steves.
Yes, I
He is a
know.
pioneer of male
Yes.
infertility. He is the one who established the Aphrodite criteria also, and all the medical management as well as the surgical management of NOA, which is the most difficult part of a male infertility, are been established by him only. So we are associated with him since last almost 4 years. He is the one who reviews our SOPs also for male infertility. Rubbing the shoulder with him, I learned a lot on the male infertility, and from that's why it's for me also it become a focus. And another reason why I taken up this as a challenge, and which have made me to take more interest in male infertility, because in India nobody is doing much of male infertility. So either is the self sperm or donor sperms. There is nothing in between. So that's where we started evolving ourselves, where we can do a lot of medical management for severely abnormal semen abnormalities to absolute abnormalities in case of an NOA, where there is a possibility that if it is in a Y microdeletion is absent, or it is an AZ FC kind of an deletions, can we offer them a medical management, and which kind of a medical management can be possible? Can we then later on, once the hormonal levels of male partner is been as per the criterias, then can we offer them micro TISA or TISA, PISA, MISA?
So means you are saying that if people having Y chromosomal defect or a micro deletion, like the AFZ or that kind of deletion, so there are treatments available. You try to give them the treatment and bring back the hormonal level in a proper
Yes, yes,
condition,
yes.
then their body can start producing some sperm, and then you can offer microtasia and other kind of process to extract the sperm from them. We were talking about this Aphrodite. Would you like, I have you have recently published this paper in Aphrodite. Would you like to tell a bit more about that research paper you
So,
had?
just like in a male female infertility, where Poseidon classification has come up, and Poseidon classification was again was a brainchild by Carlos Alvegi, Sandro Streets, and Peter Umerton, and other members also. From where there was a thought of Sandro Streets, why don't we create or standardize the male abnormalities, so that people can start categorizing the what kind of a male abnormality it is, and then for that kind of a category what treatment it should be. So the globally there should be bring up a standardization among the male partner infertility. That's where Aphrodite criteria has come up. Aphrodite criteria has gotten 5 groups, and each have their own different eligibilities and the criterias to be classified as in a group 1, 2, 2, 3, 4, and 5. Uh, and once been identified, there are specific treatment protocol is there.
So that is a good way that the male infertility, which earlier were not been in focus or not been categorized, now it is getting categorized, and now industry also know what are the different protocol to take care for different category of this Aphrodite condition. Now moving forward, means if you have to say something, where will be the what would you like to tell to the people who are looking for fertility treatment, the couples who are looking for fertility treatment?
Before being a part of a leadership group, I myself is a clinician, and I too do meet and consult the patients, and let from that angle I always tell my patients whenever what they should evaluate where they want to go, choose and pick up a uh, best clinic which is suitable for them, and once you reach over there, try to question the clinicians, embryologists, whatever the questions and queries you have related to your own problem. Try to get that answered by the clinician as many as possible. Don't keep it to yourself. Otherwise, it will surprise you in the outcome. Now, selecting a best clinic, what they can do is they should evaluate that whether the clinic has been accredited and well structured by some external body or not, whether there is a lab has its own a permanent embryologist, whether lab has got an electronic witnessing system or some safeguard are there which can take care of their embryos and all, whether the lab has got all needed technology
Equipment.
under one roof so that the outcome can come up good one. Lastly, the lab should also have enough training. All these matters when while you are choosing or picking a infertility clinic.
Ask whatever question you have when you are visiting a clinic, and also ask what are the different processes are there, how they are managing their egg, how they are managing the sperm, what are the different standards they are following, are they accredited by any organization, and then do they have a training program for their people.
Yeah,
So
and don't get fooled by false narratives runs on the social media that somebody guarantees you, somebody impresses with the best of the outcomes. In some cases, outcomes come a good one, but they don't tell you the outcomes which are poor ones. But yeah, it's what matters is what the cumulative success at a center is delivering.
in that particular point, can you tell in one sentence that what means this kind of narratives are going on in social media, how people can avoid those false narratives?
Tough to say because I've never seen my from that angle, from a patient perspective. But yeah, they should not be lured by low cost. They should not be get fooled by the that yes, we will guarantee you the success. We have the highest success. All these are a trap for you. But rather than these, you try to go to a center who, as I said, who is accredited, having a strong processes in place where the outcomes are transparently told to you rather than being a subjective line that we give guarantee you to success.
That's great. So we had talked a lot about different aspect of IVF process and IVF practices, the standards, and various research where Dr. Chandra is doing. So thank you, Dr. Chandra, for coming to this podcast, and I hope viewer will enjoy your insight and everything.
Thank you.